My name is Brian Chung. I'm the Chief Medical and Scientific Officer of the Hong Kong Genome Institute. First of all, happy 2026. Welcome to the new series of the Gene Club, our journal club, to nurture talent and to share important and interesting genomics knowledge to the audience and the wider scientific and medical community here. Dr. S.V. Liu, our CEO, always bring great speaker, and today he actually invited another great speaker, Dr. Duncan Fong. And let me introduce Dr. Fong before his talk. So Dr. Duncan Fong is an outstanding young fellow of the Hong Kong Academy of Medicine, who was awarded the prestigious Hong Kong Academy of Medicine Hong Kong Genome Institute Research Excellence Grants in the year 2023 to year 2024 for the research project titled Association between Interleukin-10 Polymorphisms with Tardive Dyskinesia in Chinese Patients Receiving Antipsychotic Treatment. He's currently working as an associate consultant in psychiatry in Kwai Chung Hospital. Beyond his clinical expertise, he's a passionate speaker who has shared his insights on the genetic foundations of mental health on RTHK's Healthpedia. Dr. Fong is dedicated to providing compassionate, evidence-based psychiatric care and advancing genomic research for better diagnosis and treatment. And today, he's going to give us a great talk on psychiatric genomics. Welcome, Dr. Fong.
Thank you, Dr. Chung. Good afternoon, everyone. My name is Duncan. I'm a psychiatrist working at Kwai Chung Hospital. Thank you, Dr. Low and Dr. Chung, for inviting me to deliver this talk here today at Gene Club. Here is what we will cover for today's presentation. In the coming 45 minutes, I will start with an overview of the current mental wellness in Hong Kong, followed by some self-help tips to maintain mentally healthy. Then we will discuss about the relationship between mental illness and genetics, with reference to the latest scientific evidence. Finally, I will briefly talk about my research topic and finish by discussing the potential of how genetic medicine can help psychiatry can work towards personalized medicine. If you pick anyone on the street and ask them to guess Hong Kong people are happy, I think you will likely get a no as an answer. A survey conducted by Mind Hong Kong last year and presented at the Hong Kong International Mental Health Conference, they interviewed more than 1,000 Hong Kong residents. They found that nearly half of them, 46% of them, experienced mild to severe symptoms of depression, anxiety, or both. 16% of them fall into moderate and severe clinical range, meaning they genuinely need help. In particular, young adults aged 18 and 29 were identified as the most affected group. These local statistics are significantly higher than the global preference, where the WHO, the World Health Organization, estimate around 1 in 7 people, which is around 14%, living with a mental disorder. So when we talk about anxiety, depression, what are we actually referring to? The mood symptoms. First of all, it is very important to understand that we all experience these mood symptoms at some point in our lives, and that's completely normal. Having mood symptoms doesn't mean that you are suffering from mental illness. But when someone experiences most of the symptoms together, and they are long enough and severe enough that affect our functioning, such as our ability to work or our ability to maintain relationship, we may need to worry about having a potential mental condition. These symptoms include a low and anxious mood, a loss of interest and motivation in things we usually enjoy, social withdrawal, negative cognition like hopelessness, worthlessness, and uselessness. Some physical symptoms are also very common, or what we call psychosomatic symptoms, like unexplained bodily pain, tremor, heart pounding, or chest tightness. Also, sleep and appetite disturbance are very common. Sometimes they are the presenting symptoms in our clinic. So, back to Hong Kong. Why are Hong Kong people particularly prone to suffer from these mood symptoms? In the Mind Hong Kong survey revealed that some significant life events are the major reasons for poor mental wellness. 40% of them reported financial difficulties, 35% were related to relationship problems, 33% related to job loss, 32% related to passing of a close friend, and 27% failed to secure a stable job. We see that the reasons are mostly related to relationship, financial status, and career. Those are the environmental factors. So when we experience these significant life events or other trauma or accident, what is actually going on in our brain and in our body that cause what we call the mood disorder or mood symptoms? First is about the endocrine dysregulations. We have a regulation system called the hypothalamic pituitary adrenal axis, or shortly called HPA axis. It is a central regulation system for most of the hormone in our body. When we experience chronic stress, this results in excessive release of cortisol, our primary stress hormone. Having adequate dose of stress hormone is beneficial to our health, but chronically high level of cortisol become toxic to our brain tissue. Also, there is neurotransmitter imbalance. Chronic stress reduces the brain cell's ability to secrete neurotransmitter. These include serotonin, which is responsible for mood regulation, and serotonin is also our primary target for antidepressants. Also, norepinephrine, responsible for attention and energy. Norepinephrine is our second target for antidepressant, as well as dopamine, what is associated for motivation and reward processing. The reduced secretion of these chemical and neurotransmitter explains some of the symptoms we just described, like low mood, low motivation. Besides the chemical, chronic stress also leads to structural brain changes. Some neuroimaging studies shows that the hippocampus will have atrophy. Hippocampal region is responsible for memory and cognitive function. Also, there is a reduced volume and activity in the medial prefrontal cortex, which is associated with emotional regulation and decision making. Finally, there is a hyperactivity of the amygdala. Amygdala is our brain fear center. So a hyperactivity of the amygdala will drive us to have anxious and panic symptoms. If you find yourself having those mood or anxiety symptoms, but they are mild enough that you do not need to seek doctor or medication treatment, what can you do to help yourself? The first and simplest step is to talk to someone you trust, whether it is a friend, a family, or colleagues next to you. Social connection is a powerful buffer against stress. Also, according to the UK National Institute for Health and Care Excellence, NICE guideline, exercise is also an effective intervention. NICE guideline recommend regular, moderate physical activity, preferably aerobic activity in group setting, at least one session per week. It can be all kinds of sports, whether it is fast walking, running, swimming, or even ball games. Physical activity helps regulate the neuroendocrine and neurotransmitter system we just described. Besides exercise, psychotherapy or counseling is also recommended. They are available in both individual and group formats. The psychologist or counselor can explore and analyze your worries, your negative thoughts, and provide an alternative way to think about it and develop some coping strategy to handle the stress. Lastly, practicing mindfulness can be very beneficial. Mindfulness is an ancient practice with more than 2,000 years of history. It was originated from Eastern tradition and brought into modern medicine and the Western world by Dr. Jon Kabat-Zinn, the photo here. He is a scientist with a PhD in molecular biology from MIT. He met a Zen teacher who introduced the term mindfulness to him. Later on, he is determined to establish a stress reduction clinic in the US and develop the mindfulness-based stress reduction program to help patients who are suffering from chronic pain and also other conditions that could not be fully treated by traditional medicine. Regarding the term mindfulness, there are different definitions, but the one he used was generally considered the gold standard. It was the awareness that arises through paying attention on purpose, in the present moment, and non-judgmentally. The most common practice we hear about is mindful breathing, but mindfulness can actually be applied to almost any activity. As long as you are following the definition, you are doing it paying full attention on purpose, in the present moment, and non-judgmentally. So whether you have a mindful walking, eating, or just like mindful listening. You may wonder why is mindfulness so helpful? Is it just a religious practice or perhaps just a placebo effect? How can it help with the mood symptoms, stress reduction, or even pain reduction? Over the past 20 years, and especially in the last 5 years, we have seen a surge in high-quality research to address the question. One of the first and landmark study was conducted in 2004 by Dr. Richard Davidson. He studied 8 long-term mindfulness practitioners, they are Buddhists, who had between 10,000 to 50,000 hours of mindfulness experience. And they found that long-term mindfulness practitioner has a significantly higher ratio of gamma band in the brain waves at both baseline and also with a further significant surge during their meditation experience. Gamma band were high-frequency brain waves associated with focus, information processing, and synchronization of brain tissues, which is the communication between different brain parts. The study also observed a marked activation in the left prefrontal cortex, which is the area of brain associated with positive emotions and motivation. A more recent systematic study in 2024 reported that an increased activation of left prefrontal cortex and also the area of brain, the cortical thickness of the prefrontal cortex and the reduction in size of the amygdala, which is our brain fear center. The most recent study published in the Lancet Psychiatry last year observed that mindfulness-based treatment lead to a significant improvement in the symptoms in treatment-resistant depression. The definition of treatment-resistant depression is that the depression symptoms are refractory to 2 or more antidepressants. This study was conducted by the UK National Health Service, and the findings suggest that mindfulness-based practice should be adopted for patients who do not respond to first-line psychotherapy or mindfulness or medication. So we have covered a lot about the definition and scientific evidence of mindfulness. But mindfulness is meant to be an experiential learning rather than just textbook knowledge. You cannot benefit from mindfulness simply by reading research paper. To fully understand how it feels, let's just take a few minutes to practice together. Now we'll play a short video to guide us through a brief exercise. So during the practice, remember to pay full attention, on purpose, in the present moment, and without judgment.
Mindful breathing. Close your eyes and rest your hands on your knees. Bring your attention to the touch of your body on your seat. Feel the weight of your body on your chair or cushion. Make sure that your back is straight and that you're comfortable. Take a few deep breaths. While you're breathing deeply, relax your shoulders, your stomach muscles, the muscles in your face, your hands, and your legs. Let go of all the tightness in your body. Now bring your attention back to your breath. Notice what it feels like as it enters through your nose, goes down through your throat, filling your lungs, and back out through your nose. Notice your stomach and chest rise and fall each time you breathe in and each time you breathe out. And just allow your breathing to be natural and relaxed. Now bring your attention to the feeling of your breath in your nose. Feel your breath as it comes in and goes out. Just focus on this sensation. paying attention to each time you breathe in and each time you breathe out. As you inhale, maybe your breath feels cool. And as you exhale, maybe it feels a little warmer. When your mind wanders, or if you become distracted, just notice what's going on in your head, and then gently bring your attention back to your breath, going in and out. Focus on the feeling of your breath and allow thoughts and feelings to come and go in the background. Now gently bring your attention back to the touch of your body on your seat and open your eyes.
I hope you enjoyed the little practice and haven't fallen into sleep. Please feel free to try this at home, as the benefit of mindfulness are more significant with consistent and long-term practice. Now I want to move on to talk about the clinical bottleneck we face in psychiatry. As a psychiatrist, we are trained to use our clinical experience to make an accurate diagnosis and offer treatment. But there are challenges in our practice. The first bottleneck is diagnosis. We rely heavily on clinical assessment. We make diagnoses by asking questions during interview and observe their behaviors to see if they fulfill specific diagnostic criteria. However, we lack objective biomarkers. There is no diagnostic blood test or brain scans that can definitely confirm a mental illness. This makes diagnosis difficult if the patient refuses to talk or if they hide up or exaggerate symptoms. The second bottleneck is treatment. The choice of psychiatric medication is often a process of trial and error. In our hospital pharmacy, we have roughly 20 antidepressants and 20 antipsychotics. If you have 100 patients suffering from depression, they will all respond differently to these medications. One patient may respond very well to a specific drug, while the other remain completely non-responsive. They also have different tolerability level. Some will have no side effects at all, while others will suffer from serious issues like heavy sedation or gastric discomfort. Currently, we can only know the outcome after we've prescribed the medication. We really want a more objective way to make this decision, and this is where genetic medicine becomes very important in future. Now we will talk a bit about the mental illness and genetics. Let's look at how we first discovered mental illness is related to genetics. It started with around 100 years ago, and with the observation study, twin study in schizophrenia patients. For general populations, the risk of developing schizophrenia is around 1%. However, for non-identical twins who share about half of their DNA component, the risk will increase to 10%. And for identical twins who share the almost identical of their DNA component, the risk significantly increased to 40 to 50%. Some may argue that it is because of the environmental factor, because twins are born and raised in the same household. But subsequent adoption study confirmed that with an increased risk, it's not about growing up in the same environment, because the risk still exists significantly when the twin siblings were raised in different households. Fast forward to today, with the technological advancement and genetic testing become more accessible, it improves our understanding of the relationship between genetic and mental illness. We now know that mental illness is not a single gene disease, meaning there isn't a specific gene mutation that directly causes a disorder. Most of the mental illness, if not all, is polygenic in nature. They involve hundreds of tiny different genetic variations, maybe thousands. Each individual at-risk gene carry a minor effect on its own, but when multiple genes add up, the risk aggregate and increase the person's vulnerability to develop a mental illness. Through genome-wide association study, GWAS, where we compare the entire genome of people with mental illness against those without to see which genetic markers appear more frequently, we have discovered an increasing number of genetic location or loci associated with mental illness. As you can see in the table, there are a few hundreds of loci found to be associated with depression, bipolar, or schizophrenia. We have also found 27 and 7 loci for ADHD and autism. The number of discovered loci increased almost every year as more large-scale GWAS study was carried out. While preparing for this talk, Dr. Brian Zhong shared with me that a GWAS was recently conducted right here in Hong Kong. This is very exciting as it is the first GWAS to examine genetic variant associated with schizophrenia clinical profile in our population. The study recruited around 1,000 patients and discovered a genetic variant that are associated with hospitalization count as well as the age of onset in our local schizophrenic patient. They also used the data to develop a machine learning model, try to predict the severity of schizophrenic patient with moderate accuracy. As the Hong Kong Genome Project continues to roll out across different psychiatric hospitals, and I know Kwai Chung Hospital is currently working on a genetic project with Hong Kong GI, we will soon have more local data which can truly help us better understand the mental illness and develop models that truly support the clinical practice. Another feature of psychiatric genetics is that one single gene can be associated with various different mental disorders. For example, there is a gene called CACNA1C, don't worry about the name. It is a gene that regulates calcium channel in the brain. It is found to be a shared risk factor for both schizophrenia as well as bipolar disorder. Another gene, which regulates our cortisol response, is associated with depression and PTSD. By the way, it is interesting to note that PTSD, post-traumatic stress disorder, is not just about having a traumatic experience. It is also influenced by our gene. The observation that one gene can affect multiple diseases tells us that some mental disorder we previously believed to be separate may actually have the shared same biological pathway. This is actually consistent with what we see clinically, where a bipolar disorder patient may have psychotic symptoms, or a schizophrenia patient may experience significant mood symptoms. A 2026 article in Nature proposed a 5-factor model. They group different mental illness according to their genetic foundations. As you can see, depression, anxiety, and PTSD are grouped into one, while schizophrenia and bipolar is grouped into another. In the past, we may believe that depression and bipolar are more close compared to schizophrenia because they are both mood disorder. However, with the genetic information, we now have a new perspective. Actually, bipolar disorder may be having a closer relationship with psychosis or schizophrenia. With further genetic discovery, we hope to establish a classification system that is more biological and genetically defined. We all know that genetic factors are very powerful, but they are not deterministic. There is actually a dynamic relationship between our gene and environment. The first relationship is quite straightforward and easy to understand, that gene is a predisposing factor. Suppose you carry a risk gene of depression, you will increase the baseline risk of getting depression. So in some point later in life, when you have an external stressor occur, such as an accident or trauma, it acts as a triggering factor that increases the likelihood of developing mental illness. Secondly, gene can influence our environment. Some genes that are not linked to any mental disorder, but are associated with some traits. For example, they are associated with impulsivity or reward deficit, meaning people may not get the same pleasure we have from normal activity. This will drive them towards high-risk activity or even illicit substance use. In turn, this will create a negative environment surround them that increase the risk of mental illness development. Lastly, there's another relationship called the switch effects. Our environment can actually regulate our gene expression. One of the processes that regulate the gene expression is called DNA methylation. For instance, we may all carry genes that are essential for brain development and neural connection. However, if someone experiences chronic stress or childhood trauma, our body may silence the gene expression through DNA methylation and leads to impaired or worsened brain connectivity, which will subsequently increase the risk of developing a mood or cognitive disorder. Now let's look at how we can apply the genetic knowledge into our current clinical practice. Again, we will use schizophrenia as an example. For a very long time, our understanding of schizophrenia was based on the dopamine hypothesis, which we believe that patients with dopamine overactivity in the brain, and it's usually typical onset time between age 20 to 30. However, the exact mechanism of why schizophrenia developed remains largely unknown. The exact mechanism is difficult to examine because the function and interaction of a living brain cells is difficult to be looked into. Through GWAS, where we scan the entire genome without prior assumption or hypothesis, we identified one at-risk gene called C4 gene. C4 is involved in synaptic pruning. The process of synaptic pruning means that our brains, during the adolescence, it will help clean up or eliminate excessive or unnecessary pathway. It is very important for brain development because it will make our brain connection and communication more efficient. However, people carrying a genetic variant that causes C4 overexpression may cause overpruning, which means our brain will cut away even the important connections. Before GWAS era, we would not have known that the role of C4 is related to schizophrenia. It's like filling a puzzle. With each discovery of an at-risk gene, we gain a better understanding of how a disease developed in our body. Another important clinical application is diagnosis. We know that certain genetic mutations are known to be highly associated with mental illness. So when a patient with known congenital syndrome comes into our clinic, we immediately become more alert. For example, Fragile X syndrome caused by FMR1 mutation. We know that Fragile X syndrome is highly associated with autism. So when patient with a known Fragile X syndrome comes in, we proactively provide more social and behavioral assessment. Similarly, for Down syndrome, extra chromosome 21, for younger Down syndrome, we also conduct more social and behavioral assessment because it is also related to autism. For adults, we will be monitoring their memory functions as well as the cognitive assessment because we know Down syndrome is associated with early onset dementia. This allows us to pick up psychiatric symptoms early and provide treatment before they become severe. Alternatively, some syndromes may not be as obvious as Down syndrome. An example is the George syndrome, the 22q11.2 microdeletions. Because it involves a relatively small missing pieces of DNA, the overall presentation can be quite variable. Some patients may look normal, and the condition can be missed for many years. I remember a patient with newly onset schizophrenia in our clinic. During the physical examination, we noticed some subtle dysmorphism. That means some difference in his facial features. And also, subsequent IQ tests also showed he had a lower intelligence. He also had a history of childhood epilepsy. So we suspect that he might be suffering from a congenital syndrome, and it was later confirmed to be the George syndrome via genetic tests. As you can see, genetic knowledge allows us to be more vigilant in picking up psychiatric symptoms in a patient with known syndrome. Sometimes it also helps us uncover the underlying genetic mutation in a psychiatric patient. The third application, which I believe is the most clinically useful, is pharmacogenetics. The prime example would be the HLA-B1502 genetic screening. For a patient suffering from bipolar disorder, sometimes we will consider the use of mood stabilizer. One common type of the mood stabilizer is called carbamazepine. Before we prescribe carbamazepine, it is mandatory to carry out a genetic test HLA-B1502, because we know patients with this genetic variant have a higher risk of developing life-threatening skin condition called Stevens-Johnson syndrome. As you can see in the picture, there is a severe skin condition where the skin will blister and peels off. This is particularly relevant for us in Hong Kong because HLA-B1502 is much more prevalent in Han's Chinese population. About 10 to 15% of us will have it, compared to less than 1% in Caucasian. This test significantly increase our medication safety and help us avoid a potentially fatal skin complication. Outside of Hong Kong public healthcare system, there are also other clinically useful pharmacogenetic applications. In particular, the CYP450 metabolic screening. It is the primary mechanism of our body, of our liver, to metabolize psychiatric drugs to clear them away from our body. If a patient have a very high CYP activity, what we call the ultra-rapid metabolizer, they may clear the medication so rapidly that the drug effect is significantly reduced. On the other hand, a patient with poor metabolizer with a very low activity, they may experience accumulation of the medication inside their body, which increase the risk of side effects as well as toxicity. We can only identify their CYP metabolic status through genetic screening. In the United States, the Food and Drug Administration, the FDA, has already integrated this information into several drug labels. For example, an antipsychotic called clozapine, they suggest a dose reduction for CYP2D6 poor metabolizer. For tetrabenazine, it is a medication used to treat an antipsychotic side effects called tardive dyskinesia, which I will cover soon. The FDA suggests not to exceed 50 milligrams per day if the patient is a poor metabolizer. There is also another international guideline called Clinical Pharmacogenetics Implementation Consortium, the CPIC guideline. They developed guidelines that recommend antidepressant dosage based on the patient's CYP status. With CYP testing, we will have a better idea of their metabolism and allow us to adjust medication dosage more wisely. I hope more genetic study can be carried out in Hong Kong in psychiatric field so that similar guideline can be rolled out locally. So much for the application for now. Next, I would like to share my own research topic conducted 2 years ago. My research topic was association between interleukin-10, polymorphism, and tardive dyskinesia in Chinese patients receiving antipsychotic treatment. As a clinician, we rarely have the opportunity and the resource to conduct a lab-based research, let alone a genetic study. So I'd like to express my sincere gratitude to Hong Kong Genome Institute for providing the grant and make this research possible. I would also like to thank Professor Lai Hei-ming at CHK for providing invaluable technical and laboratory guidance throughout the entire process. So let's look at what is tardive dyskinesia, or TD. Tardive means delayed, and dyskinesia means involuntary movement, the delayed involuntary movement. It is a potentially serious side effects that are caused by long-term use of antipsychotic medication. Clinically, it presents as involuntary movement most commonly seen in oral and facial area, such as lip smacking or tongue protrusion. Later on, I will have a video for demonstration. It is also more common with the first-generation antipsychotic. Now, with the development of second-generation antipsychotic, the side effects has been less frequent, but it still affects approximately 10 to 20% of our patients. The most challenging part of treating this side effect is that once it develops, it can be potentially irreversible, even if we stop the antipsychotic or reduce the antipsychotic medication. It was first reported as early as 1957, but after all these decades, the exact pathological mechanism is still unknown. The most traditional hypothesis for TD is dopamine hypersensitivity hypothesis. It is believed that chronic use of antipsychotics block our dopamine receptors in the brain so long that our brain tries to readjust by increasing the dopamine receptor in our brain and cause dopamine hypersensitivity. But this is not the perfect answer to these questions because we only see around 10 to 20% of the patients who are on long-term treatment develop TD, while others do not have TD. So before we continue, let's look at the demonstration video. So you can see for this gentleman, the involuntary movement in the forehead and the oral muscle with frequent eye blinking. Sometimes when the movements are very subtle, we will instruct the patient to move their limbs to distract them. In this case, we are actually still looking at their face. You can see a very minor jaw lateral movement, the side-to-side movement. For this gentleman, you can observe a slight twisting motion of the trunk. This is the upper limb involuntary movement. So for this patient, we asked them to move their hands, and we are actually looking at her foot. You can see the up and down movement of the foot. This is a more serious form of the orofacial involuntary movement with prominent lip smacking. This is the jaw movement. It is difficult for the lady to close her mouth. And this is the tongue protrusion. As you can imagine, for a patient who developed these side effects, it is not just the physical appearance. It is also associated with social withdrawal and affect their quality of life. With genetic study, we now have a better understanding of TD. We know that it is highly associated with different genes. It is polygenic in nature. It involves genes that affect drug metabolism and that determine the activity of neurotransmitter receptors like dopamine receptors and serotonin receptors. Through GWAS, researchers discovered a possible role of immune system in TD because immune system can affect our antioxidant ability in the brain. One of the factors that may be involved is interleukin-10. It is an essential anti-inflammatory chemicals that regulate our immune and antioxidant system. We knew that low interleukin-10 level could lead to more inflammation and cause inflammatory bowel disease or lupus. On the other hand, excessive IL-10 activity may lead to immunosuppression and is associated with infections or even cancer. A paper published in Korea suggested a possible association between interleukin-10 polymorphism and activity of TD. But in Chinese population, we do not have such data. For my study, I recruit 107 to 180 local patients in clinic who suffer from schizophrenia receiving antipsychotic treatment, and we divided them into TD group and non-TD group. After collecting the saliva DNA sample from the participants, we compared the 3 single nucleotide polymorphism and compared between 2 groups. Our goal was to determine whether there is any specific genetic marker more prevalent observed in one group than the other. We aim to provide a further insight into the underlying cause of TD and potentially enhance the accuracy of clinical risk prediction tool. We knew that IL-10 is unlikely to be a strong predictor of TD itself, as the condition is influenced by multiple genes, as I mentioned. Ideally, we should conduct a GWAS to compare the entire genome between 2 groups. However, our sample size is so small in this clinical study that lacked the sufficient statistical power required to achieve a meaningful outcome. Nevertheless, it is a pioneering work in this field, and I hope with the support from Hong Kong Genome Institute, more large-scale research, including GWAS, could be carried out in future. So here are some snapshots during my research. It is also conducted in the science park. I got a chance to extract the DNA from the saliva sample and do a PCR myself and learn a lot from Professor Lai. So finally, I want to talk about some potentials towards personalized medicine. First, there is a potential enhancement of disease understanding and classification, as I mentioned earlier. Our current diagnostic tool, called International Classification of Disease, ICD-10, or DSM-5, our diagnostic tool, what we call the diagnostic Bible, is purely on clinical observation. In the future, with more genetic medicine's knowledge, we hope can improve our understanding of mental illness and help us to make diagnosis with the help of biomarkers or even genetic markers on top of our clinical assessment. This will significantly increase our diagnostic accuracy. Also, with more genetic gene discovered through GWAS in different mental illness, we hope can develop an accurate calculation score, what we call the polygenic risk score, which we can calculate a patient's risk by aggregating all the genetic factors. This will help us predict the risk profile even before the onset of mental illness. Apart from diagnosis, more importantly, we hope genetic advancement can achieve personalized medicine. We hope that genetic data can help us predict the treatment response and tolerability of a specific medications to a patient, so that we can choose the right medication with the optimum dosage instead of relying just trial and error. Finally, for the pharmaceutical company, we hope genetic medicine can provide new direction for research and development, because currently the mechanism of how antidepressant and antipsychotic works still rely on the knowledge that we had 100 years ago. So when we have better understanding of our conditions like schizophrenia or drug side effects like tardive dyskinesia, we hope we can develop some target medications that can be both safer and more effective. It may be a long way to go, but I believe genetic medicine in psychiatry could be really a game changer. So that's all of my presentation today. Thank you for listening.
So thank you very much, Dr. Fong, for your excellent presentation. I really enjoyed your talk, especially the last summary slides, because it summed up very beautifully the contribution of genomics in personalized medicine for psychiatric patients. First of all, it actually helps us to understand the disease more, and therefore the classification becomes more effective, so we can do beyond the clinical biomarkers. Secondly, is about the diagnostic accuracy, and it's not just about rare genetic conditions like Down syndrome, Fragile X, or 22q deletion syndrome, which the identification is of utmost importance to benefits the clinical care, but also newer technologies like polygenic risk score that allowed us to study the common genetic etiology. Personalized treatment and new drug development is, of course, very dear to our heart, because we know that pharmacological treatment is also one of the mainstay treatment for people with psychiatric disorder. And I think in Hong Kong Genome Project, we also spent a bit of time in working on the pharmacogenomics profiling of our participants. This is really in anticipation of how we can work with talents like Dr. Fong in new areas, for example, psychiatry. And if you heard Dr. Fong's talk on the part on treatment resistant depression, schizophrenia, this is still a main problem that we need to tackle in the medical community. So I just want to use some time to explain a little bit more about the concept of pharmacogenomics. This is based on what we have done in Hong Kong Genome Project. So we work on whole genome sequencing data, but the pathway of analysis is slightly different from what we do in diagnosis. First of all, we would have to identify the pharmacogenomic locus that are of clinical relevant, and then we have to develop our own bioinformatics pipeline, and we have to refer to some of these professional guidelines that Dr. Fong has already mentioned. After our analysis, we will have to convert them into information that the clinical teams would be able to understand. For example, we would have to define for a certain drug whether the patient is a normal metabolizer, poor metabolizer, or fast metabolizer, and then we would have to correlate the finding to see whether this would impact on the clinical management. Well, pharmacogenomics in psychiatry, as well as in the other disciplines, has already helped us to determine when we start on a new drug, whether we should start on a standard dosage, shall we reduce the dosage in order to avoid side effect, or because of the anticipations of a poor efficacy, we need to increase the dosage. For extreme conditions like what we have seen, two examples in today's presentation, like Stevens-Johnson syndrome and tardive dyskinesia, sometimes it will require changing of the current drug to a new drug in order to prevent this very dreadful kind of situation. In Hong Kong Genome Project, we can see that in our analysis of the pharmacogenomic profiling of our participant, more than 99% of our participants actually carry more than one actionable pharmacogenomics finding, and on average, every one of us get around 4 to 5 such actionable pharmacogenomics variants. So this is a number we cannot ignore. I just want to show two quick examples that Dr. Fong has already alluded to as an example. ADHD, which occurs in children as well as in adults. We have studied near to 3,000 pediatric participants and look at the CYP2D6 genotypes. One genotype that Dr. Fong has mentioned in the CPIC guidelines. And as you can see, I try to highlight to you those circled in red are those what we call actionable pharmacogenomics phenotype, including intermediate metabolizers as well as poor metabolizers. What I want to show you is quite a high percentage of them, around 40% of them, actually needs some adjustment in the treatment. So you can keep the initial dosing of this drug called atomoxetine at the same level, but you need to keep it steady at this dosage for a longer period of time compared to those with normal metabolisms. And you need a very different regime in the drug monitoring. What I want to show you is another example, the last example. This is on an antidepressant, SSRI, that we commonly use. And of course, scientific advancement has led to better understanding that CYP2C19 is an important enzyme for the metabolism of this important drug, this antidepressant. So again, you can see that boxed in red are those pharmacogenomic phenotype that require drug adjustment. And we do this analysis based on 16,000 participants. These are people without psychiatric problem, but we do not expect to see very big differences between those who do and who do not have depression. What we can observe here is an alarming findings that almost 50% of these individuals have a pharmacogenomic makeup that actually require changing the drug to adjustment of the drug dosage in order to prevent the side effect. And all of us know side effects is the main reason for non-compliance in psychiatric drugs. I just want to stop here as a brief introduction so that it can stimulate both Dr. Fong and the psychiatrist who is among the audience that there is a lot that we can do in collaboration to clarify the situations of genomics in psychiatry in Hong Kong. So now this is the Q&A sessions, and it's open to the floor for questions. I would like to see if there is any people, colleagues in Hong Kong Genome Institute that would like to ask the first questions. Okay, Dr. Ma.
Yeah, thank you, Dr. Fong, for a very, very impressive talk. So I guess I have one very simple question followed by another more scientific one. So the first one will be for the mindfulness exercise. do we need to practice it for a certain, period? A length of time, say longer than 20 minutes, before it becomes effective, like what we did do in the aerobic exercise. Is there a time requirement for that?
There isn't a threshold. Doesn't mean that once we achieve certain hours of mindfulness practice, then we can change into another person. There isn't something like that, because the quality of the mindfulness practice is very variable. As you can experience just now, sometimes during the mindfulness practice, you may be distracted, and that's totally normal. But the general concept is that from scientific evidence, we observe for a longer term mindfulness practice, you will see a more significant changes. So I would encourage people to make it as a regular habit. You don't have to do like a 1 hour mindfulness every day, but as long as you find a time that you can do it like on a daily basis, and I'm sure it will be helpful in the long term.
Yeah, and the second one will be, I'm really interested in the association of TD with IL-10. So as you also mentioned, IL-10 is already like very well studied that is associated with autoimmune disease and lupus. In your point of view, or is there any data already available in the scientific literature that patients with like autoimmune disorders or lupus, they will suffer more from TD. So meaning that the effect is actually more related to a pro-inflammatory environment in our body, or it is really restricted to interleukin 10?
Okay, thank you very much for the questions. So according to latest research, patients who are more prone to having TD in schizophrenia patients are usually older age, male, or some comorbidities like diabetes. People with diabetes or with a smoking status will have a higher chance of developing TD. But in particular for those inflammatory disease like SLE, we still do not, as far as I know, I don't see any relevant data in this field, but I think this is a very interesting field to explore. Thank you.
Yeah, thank you. So this is great because the mindfulness exercise that Dr. Fong has introduced, we can actually do it in our office. We can even practice it when we are in our empty hour. And it's easy, it's breathing exercise. And I think it is something that we should all start to practice a little bit more. So I know that there is another question. Amy Tong, our scientist.
Thank you, Dr. Fong, for this very interesting talk. I have a question. I think this is becoming more and more common, that probiotics helps in everything besides, anything you can think about, basically. So I guess in the practice of mindfulness, exercise, and other things, what is your view about probiotics or the role it plays in psychiatric disorders? Thank you.
Thank you. So currently in the public healthcare system for mental illness treatment, there is no treatment that is indicated for probiotics treatment. But I know there are more and more research targeting on the probiotics treatment. In particular, for disease like autism, for disease like depressions, there are more research being done that because they believe the gut it's involved in the neurotransmitter secretion regulations. And therefore, some research conducted by the Chinese University of Hong Kong has also looking for any stronger evidence to make it into our clinical practice. And also, I know the sleep expert, Professor Wing in CHK, also examined that probiotics, the gut microbiome is closely related to one of the psychiatric disease called REM sleep behavioral disorder. So we will expect more and more research related to probiotics or gut microbiome and mental illness.
Yeah, I wonder if there are more questions from the floor. This is a golden opportunity to learn more about mental health from Dr. Fong. Okay. Jamie.
Thank you, Dr. Fong. I appreciate your presentation. So I want to know more about the support that your clinic or your hospital currently provides. So regarding, for example, mindfulness training. So I think of patients with let's say they have a high stress lifestyle. So is there any supportive programs in your clinic or hospital that can help them perform the mindfulness exercise properly?
For a patient that are eligible for that are selected for practice, we will invite them. The clinical psychologist will invite them to do group mindfulness program. Usually, the group mindfulness program will last for 8 weeks because this is the program designed by Dr. John Kabat-Zinn, and it is rolled out in worldwide, which is a evidence-based treatment for depression. So, but for individual practice, I think we do not have such treatment because it is quite labor-intensive if you carry out a one-to-one mindfulness training. But you can do it at home as well.
Understand. Thank you.
So, Dr. Fong, may I actually follow with one question after Jamie? We know that psychiatrists are very busy. I'm wondering whether there is any community resource you would recommend us. We don't, for example, I don't think that I need to see a psychiatrist, but I really want to improve my mental health status. Is there any community resource that you're aware of that you can recommend to us?
I think from time to time, you will see some mindfulness practitioner will organize some free mindfulness experience or even some day retreat to Lantau Island or places that, that can relax yourself and focus on the present moment. Yep. And I think you can, if you're interested, I'm welcome you to explore any free resources online.
So this is a very good recommendation for all of us. We don't think that we want to bother you because you're so busy, and then we can do something to enhance and maintain our mental health, which would also reduce the workload of our very busy friends in psychiatry. Thank you very much, Dr. Fong. Let's thank Dr. Fong for an excellent presentation. So I hope that you enjoyed today's session. So it remains to me to remind you of our next activity, our next Gene Club. Now we're going to learn more about bone health after we have reinforced our mental health. So next time we'll have Dr. Yanis Wong, who is actually an orthopedic surgeon, and he is going to talk to us about unlocking the secrets of fragile bone. So how genetics and AI are revolutionizing bone health. So if you want to maintain and enhance your bone health, stay tuned. Join us in the next Gene Club. Thank you very much for your kind attention.